Hello everyone, I'm Dr. Shahnd and I'm pleased for presenting our clinical audit for today. Well, our clinical audit was under the supervision of Dr. Hind Najib, Alexandria University, and alongside with our great team members, including Dr. Omar Othman. Our clinical audit was a two-cycle clinical audit called Calcium in CKD Patients, and I will start with an introduction. As we can see, chronic kidney disease, mineral and bone disorder, CKD, MBD, is a major complication in chronic kidney disease patients. Poor calcium control increase morbidity and hospitalization and healthcare burden. So in this audit, we targeted CKD patients stages from 2 to 5 in the hepatology department at Alexandria Main University Hospital. And this audit evaluated adherence to KDIGO or KDOQI guidelines for calcium management. Our research objectives, what are they? First thing, to assess current compliance with calcium management guidelines. Second thing, to implement targeted interventions and to make a change to improve our patients' outcomes. The last thing is to compare biochemical and process metrics between audit cycles. Now I'm going to discuss with you the methodology that we follow in our project. Design two-cycle clinical audit, as I said before, a retrospective plus prospective. Cycle 1 contains 24 patients and it was the baseline audit. Cycle 2 contains 28 patients and it was the post-intervention audit. What were the interventions that we made here? First thing is patients' education. Second thing is dietary support, and the last thing is medication review. Data collected were calcium, phosphate, parathyroid hormone, and updated care plans. Ethics approved, obtained, written consent collected. Now I'm going to discuss with you the results that we found in our project. First thing, I would like to ask you to take a look at figure 1 to see the graph that is about a comparison between cycle 1 and cycle 2. So what we've got is normal calcium from 25% to 57%. Hypocalcemia was 62% and became 32%. Hypercalcemia was 12.5% and became 11% in cycle 2. Patients' education, surprisingly, it was 0% and it became 68%. Dietary assessment, as patients' education, was 0% and became 60%. Medication adjustments, 33% became 75%. That was the first part of our results. The second part of our results in this project was the side effects that leading to non-compliance. Please take a look at figure 2 and you can see that a simple vertical column chart showing that 25% of patients reporting gastrointestinal side effects contributing to non-compliance. Figure 3 showing the last part of our results. The chart show that 70% of patients adhere to the recommended timing of calcium supplementation with meals after the intervention in cycle 2. The last part of the poster is the summary. First thing, targeted interventions improved calcium regulation in CKD patients. Second thing, education and medication adjustments had the most impact. The last thing is future efforts should focus on phosphate control and resource support. At the end, let me please add another thing that I believe it's a very important thing to say. Patient education is the most important thing that you need to give to your patient, because most of the patients that we found that are not adhered to their medications was because they were not educated enough by their doctors on how to take the medications, what's the doses, and what kind of food, what kind of drinks that may affect the dose of the medications. Please stay safe and thank you so much for hosting me.